Medicos. Good day to all of you. This is Dr. BK for you, and today I am going to discuss with you about the features of the ventricles, that is both the right and the left ventricle. Now, in the last session we have discussed in detail about the atrium. So what are the internal features of the right atrium and the left atrium? So how the interior is actually divided into smooth part and rough part? What are the structures opening into the right and the left atrium, and some features about the interatrial septum and a brief description about the development of the atrium. Or not only the atrium, we have seen about the primitive heart tube and its parts and how it gives rise to the various chambers of the heart. Now, in today's class, with respect to the atriums again, so we will just touch upon the external features which is particular to the atriums, that is not the atrium, the ventricles, that is the right and the left ventricle. Then in detail we will discuss about the internal features, so the interior of the right ventricle and the left ventricle, so how they differ from each other based on their function. And finally we will actually close this session with some applied aspects. Okay. Now, the right ventricle, now with the thorax, with the anterior thoracic walls removed and the lungs in situ, you see a small part of the pericardium. Okay. So you see a very small part of the pericardium, that is the exposed part which is not covered by the lungs, and that is basically a part of the right ventricle. Okay, and that part only we call it as the cardiac dullness. So this right ventricle, with respect to the external features of the heart, contributes to the 2/3 of the sternocostal surface, mainly 2/3 of the sternocostal surface and 1/3 of the diaphragmatic surface and the inferior border of the heart. Okay, inferior border of the heart. Some textbooks also describe there is also a posterior surface which is formed by the area overlying the ventricular septum. Okay, so we will just stick on to what majority of the books describe. So mainly 2/3 of the sternocostal surface, 1/3 of the diaphragmatic surface or the inferior surface. Then it mainly contributes to the inferior border of the heart. So that is the area of cardiac dullness, where the pleura and the anterior border of left lung deviates, forming the cardiac notch. So this area is in direct contact with the anterior thoracic wall, separated only by the pericardium. Okay, so that is the diaphragmatic and inferior border of the heart. So the inferior border of the heart extending from the opening of the inferior vena cava near to the apex. There, now what you are able to see, 2/3 mainly is your sternocostal surface contributed by the right ventricle. The right ventricle is actually separated from the right auricle by the atrioventricular sulcus. Especially the atrioventricular sulcus is a continuous sulcus, C-shaped sulcus. It goes behind, comes anteriorly. Actually what happens is it is interrupted by the outflow tracts of both the ventricles. Especially anteriorly you see the outflow tract of right ventricle which is interrupting, that is the infundibulum. Okay, so that is the atrioventricular, mainly the right half of the atrioventricular sulcus, and in that groove or sulcus you see the, what you see is the trunk of right coronary artery. Then the two ventricles are again separated by the interventricular sulcus. The two ventricles are actually separated by the interventricular sulcus. So that is actually the surface projection or the area which is demarcated for the interventricular septum. Now on the interventricular sulcus, anterior interventricular sulcus, we also have an interventricular sulcus posteriorly. So these two separates the right and the left ventricle externally. Anterior interventricular sulcus lodges your anterior interventricular branch of left coronary artery. Posteriorly you have the posterior interventricular branch of right coronary artery. Okay. Now the interior of the right atrium communicates with the right ventricle to the tricuspid orifice or the right atrioventricular orifice. Now here you can see the right ventricular wall, the anterior wall of the right ventricle is cut open so as to view the interior of the right ventricle. So here the anterior wall has been cut open and this is the reflected part. Now you are able to see the interior of the right ventricle. The interior of the right ventricle mainly consists of two parts. You call it as a rough part again and a smooth part. There in atrium we told rough anterior part and smooth posterior part. But here we call it as rough inflow tract and smooth outflow tract. Okay, the inflow tract is rough and the outflow tract is smooth. Okay. The outflow tract is also called as the infundibulum or conus arteriosus. It is called as infundibulum or the conus arteriosus. Okay. The inflow tract and outflow tract is separated by a ridge which is actually called as the supraventricular crest. Okay, which is actually called as the supraventricular crest. Supraventricular crest. Between the outflow tract and the inflow tract, we have a ridge which is called as the supraventricular crest. So the inflow tract is rough and the outflow tract is smooth. The outflow tract is situated above, in front and to the left of the inflow tract. Okay, the outflow tract is actually situated above, in front, anterior to and to the left of the inflow tract. Now the inflow tract as it is developed from the primitive ventricle. We saw the parts of the heart tube. So you have from above downwards, you have the bulbus cordis. Above the bulbus cordis you have the conus arteriosus, okay, or truncus arteriosus. Then we have the bulbus cordis, then we have the primitive ventricle, then we have the primitive atrium, and then we have the sinus venosus. This is from above downwards. Okay. The rough inflow tract is developed from the right part of the primitive ventricle, and the smooth outflow tract is actually developed from the bulbus cordis, also called as the conus arteriosus, the outflow tract. So that is the inflow tract, and the entry point is actually guarded by the tricuspid opening, which has three cusps or leaflets, a valvular leaflets, tricuspid valve, they form the tricuspid valve, and that is actually the outflow tract, and the outflow tract again enters pulmonary trunk, the opening pulmonary orifice, that is again guarded by the semilunar valves. Okay. See here how actually the inflow tract, if this is the sagittal plane, the tricuspid opening is actually 45 degrees from the sagittal plane, and it is directed towards the apex of the heart. So blood flows downwards and towards the left side, apex of the heart. Then the blood during ejection has to pass through the outflow tract, so it makes an obtuse angle. The blood actually takes an obtuse angle. So you are able to see many ridges and something running in between the walls. They are called as ridges. Ridges, bridges, all those things you are able to see here in the inflow tract, whereas outflow tract is smooth and it is actually developed from the bulbous cordis. So let us try to understand this one by one in detail. Now first starting is the right atrium communicates with the right ventricle through the tricuspid orifice. The tricuspid orifice is actually guarded by the tricuspid valve, which is also called as the tricuspid valve complex. Okay. Tricuspid valve complex. Now this tricuspid valve complex is mainly made up of, first the orifice, here we have seen the opening, then this is actually the tricuspid annulus. Then we have the three cusps or leaflets. Then chordae tendineae attached to these leaflets. One end of the chordae tendineae is actually attached to these leaflets. The other end is actually attached to the papillary muscles. So the tricuspid valve complex is made up of tricuspid annulus, leaflets, chordae tendineae and the papillary muscles. Now look at the tricuspid orifice, it will allow the tip of 3 fingers. Okay, it will allow the tip of 3 fingers, and the annulus, here you are able to see the annulus is actually a fibrocollagenous ring or rim, mainly derived from the fibrous skeleton of your heart. Okay. So the fibrous skeleton of the heart is again a different topic. Right and left fibrous trigone we have, and from that we have the collagenous ring. Okay, collagenous ring, lamina cribrosa, it is formed. Then attached to this collagenous ring is the leaflets. There are 3 leaflets, anterior, posterior and septal. Okay, anterior, posterior and septal. You see 3 leaflets, anterior, posterior and septal. The septal leaflet is the smallest of the 3. The septal leaflet is the smallest of the 3, and these leaflets are actually separated by commissures or indentations. They are separated by commissures or indentations. If you carefully observe each leaflet, it will have 3 zones. It will have a basal zone, it will have a clear zone, then it will have a rough zone. It will have a basal zone, it will have a clear zone, and then it will have a rough zone. Now, to the free margins you are able to see what is attached is the chordae tendineae, tendinous cords. That is why it is actually called as the chordae tendineae. The chordae tendineae attaches to this rough zone, and it is also attached to the basal zone, but not to the clear zone. Okay, to the basal zone and the rough zone you can see, but not to the clear zone. Next, what you see is the chordae tendineae. The chordae tendineae are again, you have true chordae tendineae and false chordae tendineae. The true chordae tendineae are the one which connect the papillary muscles to the cusps. Okay. Whereas false chordae tendineae, they just run across the walls of the ventricle inside, but they don't connect the cusps with the papillary muscles. Okay, that is the difference between the true chordae tendineae and the false chordae tendineae. Same way, the chordae tendineae, as we have classified the cusps, also the true chordae is also called free chordae, basal, commissural, marginal. Like that, you can classify them based on the area where they go and attach. Chordae attaching to the basal zone, chordae attaching to the commissurals, they are commissural chordae, chordae attaching to the rough zones. So like that, you can classify this chordae tendineae. Then followed by that, what you are able to see is the papillary muscles, anterior and posterior papillary muscles. Again, there is a different of opinion. Some books describe there are only 2 papillary muscles, but some books they tell there are 3 papillary muscles for the right ventricle. So, basically we have seen some chordae and then papillary muscles and some ridges. So that is why the interior of the right ventricle, the inflow, rough inflow tract is also called as trabeculae corneae. Okay, it is actually called as trabeculated. That means it is divided into numerous partitions. Okay, trabeculated, and that is why it is called as trabeculae corneae, and made up of ridges, bridges, and papillary muscles. You see numerous elevations, they are actually called as the ridges, and something running from one wall to the other wall, and they are called as the bridges. And of course, then you see the papillary muscles. So inflow tract is actually called as trabeculae corneae and made up of bridges, ridges, and papillary muscles, which are called as the pillars. Of the numerous ridges, numerous linear elevations you are able to see here, one elevation is very important and marked, and that is called as the supraventricular crest. So this elevation you see here is actually the supraventricular crest. It extends from the interventricular septum, right surface of interventricular septum, to the AV opening, to the atrioventricular opening. That is called as the supraventricular crest. It is actually developed from the bulboventricular flange. The bulboventricular flange. Okay, the ventricular part, and this is the bulbous part. That is the demarcation between the inflow tract and the outflow tract. Bulbous cordis. The bulbous cordis can again be divided into conus and truncus. Okay, so that is about the supraventricular crest, which is developed from the bulboventricular flange, extending from the right surface of the ventricular septum to the atrioventricular opening. So I told you papillary muscles also 2, or sometimes you see 3 papillary muscles. Anterior, posterior, you also have a septal papillary muscle. Okay. So first we have seen about the ridges, of which the special mention is the supraventricular crest. Next we are going to discuss about the bridges, which actually run across the cavity and connect the ventricular valves. Okay, so just kindly make a note of it. I have given it as ridges, it is not ridges, bridges, because they only run across the cavity and connect the ventricular valves. One of the bridge is again very important, and it is called as the septomarginal trabeculae. septomarginal trabeculae, again what happens is it extends from your right surface of the interventricular septum to the anterior papillary muscle. Okay. So right surface of the ventricular septum to the anterior papillary muscle is the septomarginal trabeculae, or also called as the moderator band. This prevents the over distension of the right ventricle. Okay. So this acts like a checkpoint or check valve. So the right ventricle cannot bulge too much. Okay. And this also conveys the right branch of the bundle of his. You have right and left branch of the bundle of the his. So this conveys the right bundle of the his. It's a part of the conducting system of the heart. So on the ridges we have seen about the supraventricular crest, and about the bridges we have seen about the septomarginal trabeculae. Next, you see the papillary muscles. So anterior papillary muscle, and then you have the posterior papillary muscles. Anterior papillary muscle from the sternocostal surface to the anterior and posterior leaflets. It connects via its caudate tendinae to the anterior and posterior leaflets. Posterior are also called as inferior papillary muscle. Inferior papillary muscle connects the posterior and the septal leaflets. Okay, posterior and the septal leaflets. That is the posterior papillary muscle. But some books also describe the septal papillary or medial papillary muscle connecting the anterior and septal. Okay, but here I have given description for two papillary muscles, anterior and posterior. Most commonly found is the anterior and posterior papillary muscles. Anterior one from the sternocostal surface to the anterior and the posterior leaflet. Posterior or inferior papillary muscle from the inferior surface, inferior wall. From there, through the cauda tendinae, it attaches to the posterior and the septal leaflet. Okay. So contraction of the papillary muscles, what happens is aids in closure of these leaflets via pulling the caudae tendinae. Okay. So that is actually a very closer view of the papillary muscle, caudae tendinae, which is attached to the cusps. So while this muscle contracts, this caudae, they pull and approximate the cusps. So the rough part approximates with the atrial surface of the adjacent papillary muscles. They also prevent the inward turning of the cusps. So the cusps, what happens, should not get inturned towards the atrium. That also will lead to defective closure of these valves. Okay. You can see caudae tendinae running all over to all various zones of the cusps. I already told you each cusp has got a basal zone, clear zone and a rough zone. So they are mainly responsible for the perfect closure of the tricuspid valve. So now we will come to the outflow tract. So here you see the outflow tract, which is actually called as the infundibulum. So it is smooth, there is no bridges or ridges, conical. So that is why it is also called as conus arteriosus. Developed from the bulbus cordis and situated above in anterior and to the left of the inflow tract. So its apex is guarded by a valve which is actually called as the pulmonary orifice. So here you are able to see the pulmonary orifice. They are guarded by three cusps, which are actually called as the semilunar cusps, okay, or semilunar valves. Semilunar valves or cusps. So they actually project into the pulmonary trunk, and we have a center nodule, and on either sides we call it as the lunula. So you are able to see that is the center nodule, and from there you are able to see that is actually the lunula. Depth of the cusps has got a dilatation, which is actually called as the pulmonary sinus, dilatation of pulmonary trunk above the each cusp, and that is called as the pulmonary sinus. So outflow tract is also called as infundibulum. The apex or upper border of the outflow tract, upper part of the outflow tract is guarded by the pulmonary orifice, which is guarded mainly by the pulmonary valve. They are semilunar valves or the cusps, and see they are actually projecting into the pulmonary trunk, project above into the pulmonary trunk, and they actually present a nodule and then a lunula. Then above that opening you have a dilatation, which is called as the pulmonary sinus. So we have discussed about the right ventricle, its external and the internal features. Now we will move on to the left ventricle. So the left ventricle mainly contributes to the 2/3 of the diaphragmatic surface or the inferior surface. It also contributes to 1/3 of the sternocostal surface. Then the left lateral surface and the left border of the heart. Then it also forms mainly the apex. Apex, the pointed area, apex, which is actually lies over the 5th intercostal space. So apex is mainly formed by the left ventricle, apart from the most of the diaphragmatic surface and 1/3 of the sternocostal surface. So mainly the left ventricle is related to the cardiac impression of the left lung. Okay, so between the lung and this you have the left ventricle, and the lung you have the mediastinal pleura, here the pericardium, and between the pericardium and the pleura you have the pericardiophrenik vessels and the phrenic nerve, pericardiophrenik vessels and the phrenic nerve. Okay. Now if you look at the interior, you see how thick the walls. It is 3 times more thicker than the wall of the right ventricle. Okay, because it needs more power and it has to exert a lot of pressure to pump its blood into the aorta for the systemic circulation. So that is why what happens is it is more thicker, and the interior, the outline of the interior is also circular. The cavity is actually circular, the left ventricle, whereas the right ventricle, it is somewhat semilunar or crescentric. You can call crescentric or semilunar, because the ventricular septum projects into the right ventricle. Okay, you are able to see the deviation of the right ventricle, deviation of the ventricular septum into the right ventricle. So that is why the right ventricle has a semilunar cavity shape of this cavity, whereas the left ventricle is circular. So here you are able to see the interior of the left ventricle. Interior of the left ventricle, again it has got 2 parts, an inflow part or the inflow tract and the outflow tract. Okay, so interior has again 2 parts, the inflow tract and the outflow tract. The outflow tract here is called as the aortic vestibule, which is smooth. It is called as the aortic vestibule. Here we call it as the infundibulum, but here the outflow tract of the Left ventricle is actually called as the aortic vestibule. It is smooth, whereas the inflow tract is rough. The inflow tract and outflow tract is separated by the base of the anterior leaflet of the mitral valve. So the subaortic curtain. Okay. So bicuspid valve, left AV valve, anterior leaflet, cut part you are able to see here, and the subaortic curtain. This separates the inflow tract from the outflow tract, and the outflow tract is situated above, front, and to the right of the inflow tract. Now the blood from the inflow tract to the outflow tract has to make an acute angle. Here it makes an obtuse angle, but here it makes an acute angle. Okay. So as I told you, the inflow tract is separated from the outflow tract by the subaortic curtain. So subaortic curtain is nothing but here you have the aortic annulus. There will be two scallops, anterior and posterior. They again will be derived from the fibrous trigone of the heart, fila coronaria. So between the anterior and posterior scallops of the aortic annulus and the mitral valve cusps, there is a gap which will be filled by the subaortic curtain, and this is your valve, anterior leaflet of the mitral valve. They both separate your outflow and the inflow tract. So same as that of the right ventricle, the inflow tract of the left ventricle is derived from the primitive ventricle, left part of the primitive ventricle, and outflow tract from the bulbus cordis, left part. That is from the right part of bulbus cordis is the infundibulum, outflow tract of right ventricle. Here it is the left part of the bulbus cordis, left part of bulbus cordis for the outflow tract of the left ventricle. So same way here you are able to see the mitral valve complex. Now the atrioventricular orifice is actually smaller than the tricuspid orifice. Okay, it is somewhat smaller, and the mitral valve complex same as that. It is made up of leaflets or cusps. There it is 3 cusps. Here it is only 2, anterior and posterior. There is no septal cusp. Then you have chordae tendineae followed by the papillary muscles. 2 papillary muscles, anterior papillary muscle and posterior papillary muscle. Only 2. Because it is cut, it is shown as 2 parts. The anterior itself is shown as 2 cut ends. The trabeculae corneae, the ridges and bridges are more numerous. The ridges and bridges are actually more numerous in case of the left ventricle as compared to that of the right ventricle. Okay. Anterior papillary muscle attaches to the sternocostal surface, same as that of the right ventricle, and posterior papillary muscle attaches to the inferior wall, and both papillary muscles gives chordae tendineae to both the leaflets, anterior and posterior leaflets. Now the other thing with respect to the mitral valve complex, anterior leaflet, posterior leaflet. Anterior leaflet does not have all the 3 zones, basal, rough and clear zones, but posterior leaflet has got all the 3 zones. Now apart from that, the anterior leaflets receives a chordae which is called as the strut chordae. They are very strong chordae arising from the anterior papillary muscle to the anterior leaflet. They are called as strut chordae. Apart from that, the chordae tendineae classification is same as that of the right ventricle. It attaches to the basal zone, then to the rough zone, and you have free cardia, true cardia and false cardia. True cardia again free, marginal, commissural. So all those classification remains the same. So cardia of both papillary muscles attached to both leaflets of the mitral valve. So the outflow tract is actually called as the aortic vestibule. Okay. So that is actually called the aortic vestibule. I told you this part by the anterior leaflet and by the subaortic curtain separates the inflow tract from the outflow tract. The aortic vestibule is again guarded by semilunar valves. Okay. This aortic vestibule is almost fibrous. There is no muscle tissue at all. Very scanty or minimal muscle tissue. It is mostly fibrous. So as I told you, the aortic opening is actually guarded by the aortic annulus. The vestibule is guarded by aortic annulus. Okay, sorry, here you are able to see here. It has got one anterior and two posterior, cusps, and they project into the ascending aorta, and each in the center has got a nodule and the lunulae. So this center nodule and lunulae on either side. So deep to the cusps you see a sinus and you see openings which is actually called as the aortic sinus of Valsalva. Aortic sinus of Valsalva. So this, how many aortic sinuses are there? 3 aortic sinus are there, of which one is actually a non-coronary sinus. Okay. So each cusp in the depth you see a dilatation with the opening which is actually called as the aortic sinus of Valsalva. So right anterior sinus, okay, right anterior sinus and left posterior sinus, right anterior and left posterior, these two gives origin to the right and the left coronary artery, whereas right posterior you don't see any opening, and that is actually called as the non-coronary sinus. Okay, and that is actually called as the non-coronary sinus. Right posterior is non-coronary, whereas right anterior and left posterior gives rise to the coronary sinus. So that means blood gets filled and the coronary arteries receives its blood supply only during the ventricular diastole. Okay, ventricular diastole, because when the ventricular systole heart compresses, these valves are opened, so these cusps go and approximate near the wall of the aorta or the aortic vestibule and blood flows out. Then during the diastole of the ventricle, these cusps they close the valve, so blood comes and stays here in this aortic sinus of Valsalva, these dilatations, and when the blood stays here it passes into this coronary arteries. So coronary arteries mainly receives its blood supply during the ventricular diastole, whereas during systole the all parts of the body systemic circulation receives its blood supply. Okay, and right posterior there is no artery arising, so it's a non-aortic sinus. So the right and left ventricle are separated by a septum which is actually called as the interventricular septum, which again has two parts, muscular part and a membranous part. Okay, it is the muscular part and membranous part. Convexity is towards the right ventricle and obliquely placed. Muscular part forms the antero-inferior part of the septum, and the membranous part forms the posterior-superior part of the septum. Antero-inferior is muscular and posterior part is mainly by the membranous part. Okay, mostly it is membranous. Muscular part is again developed from the primitive ventricle, The membranous part is developed from the bulboventricular septum or bulbar septum. Okay, it is actually developed from the bulbar septum, and there is also a small contribution from the AV cushions, atrioventricular cushions. Septum intermedium also finally comes and closes the or completes the septum. So from three sources: septum intermedium from AV cushion, membranous part from bulbar septum, and muscular part of the septum is from the primitive ventricle. Coming to the applied aspects, so interventricular septal defect, so defective formation in the septum. Naturally you have an interventricular foramen, and mostly the septal defect is found in the membranous part rather than the muscular part. Okay, affects the membranous part, persistent interventricular foramen. So mixing of the oxygenated and deoxygenated blood, so the baby might become cyanotic, blue baby or cyanotic. Okay, because of the deoxygenated blood supplied via the aorta to the circulating to the systemic circulation. So one very common interventricular septal defect is actually called as the Fallot's tetralogy or tetralogy of Fallot. It is actually a combination of 4 defects. So this is a normal heart, this is tetralogy of Fallot, where you have these 4 features: hypertrophy of the right ventricle. You are able to see how thick the right ventricle has become, musculature, hypertrophy of the right ventricle. Then interventricular septal defect. Septum is not formed, membranous part, it is very defective. It is called as interventricular septal defect. Pulmonary stenosis. Okay, so the opening is actually stenosed or completely, what happens is obstructed. Pulmonary stenosis you are able to see, and overriding of the aorta. Okay, so what you see here is the overriding of the aorta. So these are the 4 symptoms of Fallot's tetralogy. I will repeat: right ventricular hypertrophy, interventricular septal defect, pulmonary stenosis, and finally what you have is the overriding of aorta. You also have a pentology, and this is combined with atrial defect, atrial septal defect. It is actually called as pentology. Now apart from that, so valvular stenosis or valvular insufficiency, valvular stenosis or valvular insufficiency. In valvular insufficiency, what happens is the valves might be defective and it might bulge like a parachute into the atrium. Instead of perfect closure, one of the valves or one of the leaflet might bulge, and they might produce regurgitation, reverse flow of blood. Now if the regurgitation is very minimal, it might be asymptomatic, no treatment is needed. Okay, but as it progresses and if it is going to cause some diseases or manifest into some diseases, then intervention is definitely necessary. Okay, so valvular stenosis is, so when the valves are not functioning, okay, so it might not open. Mitral valve stenosis or aortic valve stenosis. In mitral valve stenosis, naturally the left atrium, what happens, will get dilated or bulged. Mitral valve prolapse, mitral valve prolapse might take place. In mitral valve prolapse, you hear a murmur, which is actually called as the click murmurs. Okay, so because of regurgitation of the blood takes place. Now again, mitral valve prolapse, what happens is it might be present without any symptoms, no major lifestyle changes is necessary until there is some symptoms or other underlying diseases. Okay, so most common symptoms might be fainting, fatigue. Then what happens is, in mitral valve stenosis, sometimes you feel pain but not arising from due to the coronary artery or blood obstruction when lying flat or during physical exertion. Okay. Physical exertion or when lying flat, or these valves might get affected in connective tissue diseases, or if they are infected, even valves can get infected, or they might get affected due to some connective tissue diseases. In worst cases, surgical intervention is necessary to replace the valves, whether it is the mitral valve or the aortic valve. So that is about the right ventricle and the left ventricle. So thank you very much for your patient listening.